Well, welcome everyone. On behalf of the Dialogue Innovation team, which is Beth Resnick and I, who decided that one of the conversations that we want to have on campus is about the role of religion in public health, a question that is on many people's minds, but often spaces to have this conversation are limited on campus. So we thought that this would be a wonderful opportunity to take advantage of. So we want to just acknowledge, firstly, the support of the Dialogue Innovation Initiative and also the Berman Institute for co-sponsoring this seminar series with us. My name is Johnathan Ehsani. I'm an associate professor in the Department of Health Policy and Management in the School of Public Health. And my own research touches on issues of adolescent development risk and injury. But in that domain, we see many instances where there are questions about human motivation, human nature, about how we see ourselves in the world, our purpose, and how that defines our behaviors. And so we see the role even of religion, spirituality, and public health in very applied fields of public health. This seminar series, which we're having, this is the first one I'm very pleased to be kicking off today, is dedicated to exploring the synergies between public health and religion. And I'm very pleased to be welcoming our colleague from Emory today, Ellen Eidler. But before I introduce her, I also want to acknowledge that we are actually at a very special time of the year where there are many religious traditions, festivals, and moments that we want to mark. It's the holy month of Ramadan, it's Lent, it's the Baha'i festival of Ayamiha. And if there's anything that I've missed, please just let me know. But happy holy days, happy fasting, and Ramadan Mubarak for anyone who is, and Eid Mubarak for those who are fasting. So with that, I'm going to take a moment to tell you a little bit about our speaker today. Dr. Ellen Eidler is the Samuel Candler Dobbs Professor of Sociology and Director of Emory's Religion and Public Health Collaborative, with additional Emory appointments at the Rollins School of Public Health, the Center for Ethics, and the Graduate Division of Religion. And as someone who is so accomplished and so senior, Dr. Eidler, whose work was familiar to us, to a group of us who were in a public health reading group. We'd read her papers. She has a wonderful book called Spirituality as a Determinant of Health, and is well known in the field. So you can imagine our utmost joy and delight, where within minutes of inviting her to speak at this seminar series, she responded positively, has been extremely gracious and accommodating, and it's my joy to welcome her to the podium. Thank you, Ellen.
Thank you. Thank you. I'm delighted to be here. I've never been to Hopkins before, coming from a different school of public health. And so yes, I would like to share a talk with you that I have done a couple times already. And I know that we want to save some time for questions. So I'm going to keep my eye on the clock, and I might skip past some completely charming slides that I'm sorry you won't be able to see. I know some people talk too long, so let me just get with it. The evolution of research on religion and health goes right along with my, higher education and profession. So this is a little bit biographical, but I think it's more of an intellectual history than it is a personal one. I'm hoping so. Anyway, so okay, try a different way. I guess I have to use the things at the bottom. Sorry. there's more than one way to get it. So I started my teaching career at Rutgers University and from 1985 to 2009. I was a faculty member in the Department of Sociology, but also at the Institute for Health Policy and Aging Research that was directed by David Mechanic. And then in 2009, I was invited to Emory University to direct the Religion and Public Health Collaborative, which is an initiative that had started there and was already somewhat underway when I came. So this talk is really about the evolution of research that took place from my really graduate student career all the way through to today. And the talk is roughly structured in three parts: the individual level, the institutional and partnership level, and then the state level. And I would like to just share some examples of research in those areas. So starting with the individual, or you could think of it as the micro level, it's about individuals. And in public health, my affiliation with Rollins School of Public Health is in the Department of Epidemiology. Lots of research is based on surveys, and there are some surveys, not many, but there are some that do ask people about their religious participation, religious attendance, and sometimes some other more subjective questions, and sometimes also the affiliation, Protestant, Catholic, Jewish, other, or none. And so this is where my research started in graduate school and in my early career at Rutgers. And, I'll summarize some of it for you, but this was the starting point. It's not the ending point, but it's the starting point. So at Rutgers, I continued to do research on data from the Yale Health and Aging Project, which was starting at Yale when I was a graduate student there. And I was very, very fortunate to be there when they were collecting the baseline data. And then I just, insinuated myself into the situation so that they kept giving me the follow-ups as they continued to do them from 1982 through 1994. So I was blessed, absolutely, that I had dissertation data on a topic that I was really interested in when I came to graduate school, but that fortunately a big professor at the School of Public Health was also interested in. Stan Castle was a mentor to me, and he was responsible for putting 5 questions on the Yale Health and Aging Project. That was one of the, for some of you may know, of older studies of older adult health, the EPIS studies, Established Populations for Epidemiologic Study of the Elderly, and New Haven was one of the 4 sites. It was the only site that had questions on religion, though, and that was because of Stan Castle. My other mentor at Yale was Lisa Berkman, who was at Yale initially and then went to Harvard. So this is just an example of one of the studies that Stan and I did. We saw that baseline levels of attendance at religious services were associated longitudinally with lower levels of functional disability. This is an older population. That was one of them. Here's another one about the timing of death around holidays. I became aware of a study about older people's deaths around their birthdays, and the researcher thought that well-known people should be less likely to die before their birthday than after it, and so he studied encyclopedias anyway. It was an interesting line of study, but I thought, oh, well, wouldn't religious holidays be something that people really look forward to in old age? And so guess what? There were a lot of deaths in the sample, and so we tracked the 30 days before religious holidays and the 30 days after, and it was just as true in New Haven that older people were less likely to die before the religious holiday than after. Fortunately, there's a quite good religious diversity in New Haven, a large elderly Jewish population, about half Roman Catholic because it's an Italian city, but also Protestant. So we were able to compare the deaths of Jewish people around Christian holidays and of Christian people around Jewish holidays. And guess what? No patterns there, but the patterns for the religious holiday that belong to you were quite significant. So that was another really fun paper that we did. And then this last one that I'll give you as an example was actually done at Emory. And we used health and retirement study data to examine patterns of mortality. And the health and retirement study, some of you know, I'm sure, is for people age 50 and older, a large representative sample of US people. And we had measures of religious attendance, religious affiliation, and also a question about how important is religion to you. We saw that people who attended religious services frequently were 40% less likely to have died over a 10-year period than people who never attended services. My wonderful colleagues, John Blevins, Mimi Kaiser, and Carol Hogue will play further roles in this talk, but it was a great group of collaborators. Okay, that's all I'll say about that right now. So anyway, so this is one of the many mortality studies that I would like to share with you. Some of you may be aware of this big study that was published in JAMA in 2022. A group of researchers from Harvard did a huge systematic and even meta-analysis of studies about religion, spirituality, and health. This is a complicated paper. There are really two papers in this paper. One of them is about serious illness, and Tracy Balboni, who is the first author of the study, was the head of that part of the study. And the other part is about population health outcomes, and Tyler Vanderbilt was the head of that part of the study. I was not a co-author on this study, but they used a Delphi panel approach to assess the quality of the studies to be included in the systematic analysis. And I was on the Delphi panel, so I was aware of all of the work that they were doing. This was absolutely enormous. I think they had 17 people doing this for 2 years. If any of you have done a systematic review, you know how much trouble it is. This is a lot of studies. So I won't say anything about the Balboni serious illness part of it, but I know you can't read that, but this is one of the tables for the health outcomes part of it that I was on that half of the study. And so here are some of the outcomes: all-cause mortality, physical health, health behaviors, mental health, and quality of life were the areas that they assessed studies in. They conclude in the study that the area for which there is the most strong evidence is this first one, that the single variable of religious attendance at services is a strong predictor of all-cause mortality in 30 out of 31 studies. They found a significant effect. And because the studies were comparable enough, they were able to do a meta-analysis and concluded up here that the hazard ratio for people who attend frequently was 0.73, meaning that about 27% reduction in mortality for people who attended religious services regularly. And that was after adjustments for all kinds of things. So I guess I should, I mean, you're all in public health, right? So it's actually important to adjust for the health status of people and for their sociodemographic variables and their socioeconomic status and even their health behaviors, their smoking and alcohol use, all of that stuff. So any of these good studies all did those things. So the effect of religious attendance was net of all of these other possible, somewhat causal pathways. So it's a wonderful study. If you haven't seen it, it should be on your reading list. So just to summarize this individual level of research, it's pretty strong. I mean, this was what I was always doing. You know, if you throw religious attendance in there, you're going to get a significant effect. If you're a young assistant professor, you can publish enough papers on it. And even though nobody else was really interested in this except a very few number of people, it definitely got me tenure, got me promoted to full professor. So it was a very, very reliable analysis that I could do. But it was really important to say that religious attendance was the powerful variable. And the more subjective measures of religion, such as, is religion important to you? I feel like I'm a deeply religious person. Do I get a lot of strength and comfort from religion? Those items were on the Yale Health and Aging Project. The importance one is on the HRS. They don't have any association with mortality, and sometimes even in the opposite direction. So in the HRS, we did see that people who said that religion was important to them were a little bit, not a lot, but a little bit more likely to have died over the 10-year period than people who said religion wasn't important to them. So, and this is after adjusting for everything. So it was clear to me that that in the ballpark here, it was the social part of it. And I'm a sociologist, right? It was the social part. It was the getting together with people. It was the connections to the community that made a difference. And however you felt in your heart didn't really matter that much, at least for health outcomes that were measurable. So those are important to say. And then, all these causal pathways, people who are more frequently attending religious services are less likely to smoke or drink heavily or have many sexual partners. And there's a lot of health behaviors that are strongly associated with attendance that would absolutely be mediators. They are on the causal pathway. But social support and networks and social capital are really important too. So that was all great. But that's not all there is, as they say. So moving from Rutgers to Emory was a big change in many ways. Rutgers is a wonderful school, and I had a great bunch of colleagues there, but they didn't have a school of public health at that time. They do now, but they didn't then. And the religion department was like a micro service department for undergraduates that didn't really, so there weren't really any colleagues in the two things I was studying to really work with. And then I went to Emory with the Candler School of Theology and the Graduate Division of Religion. You mentioned that. That's actually the entire religion department faculty, which is huge, and the entire Candler School of Theology faculty, which is also huge. And that's like a giant bunch of people who study religion. It was wonderful. I loved it. Well, still do. And also then the Rollins School of Public Health, which is growing gangbusters. So the second part is really about how agencies can form partnerships with each other at the institutional level. This is quite different from studying individuals and health outcomes. And it's really, really a part of Emory's history, because the Carter Center and Emory, I don't know how many of you have visited Atlanta, but the Carter Center is like 8 minutes away from campus, and the Carter Center and Emory are very tied to each other in many ways. So it was a whole other way for me to be thinking about it, and I can only say that I grew a lot. So here's a little history. On October 25th, 1989, there was a conference at the Carter Center. And here's President Carter and Mrs. Carter, and this very tall man is William Fegge, who you all know, I'm sure, died about 3 weeks ago. It has been an absolute honor to be in the same room with him numerous times at Emory. So he was director of the Carter Center. He was also director of the CDC, and really like a major force in public health in the world. This is there, and you can see it says the church's challenging health, but really it was a multi-faith group that was invited. And this is the little booklet that they put out. So the President Carter, in his remarks at the conference, said, and this is a quote, "There is no church or synagogue in America that could not coordinate and carry out an immunization drive against measles." Those words were said in 1989. So out of this conference came something, yes, we're good, thank you, came something called the Interfaith Health Program. It was a little more complicated than that, but for our purposes, the Interfaith Health Program started and was funded from the Carter Center initially. And then in the year 2000, I think it moved to the Rollins School of Public Health. And the Interfaith Health Program acting director, actually, he's the real director, is John Blevins, and these other people. Well, what can I say? You all know what happened to PEPFAR funding, don't you? PEPFAR funding was the major part of their budget. So if you go to the IHP website now, you'll find it hasn't been updated recently. We are in the process of combining some websites, but yes, it's very sad what is the present state of IHP is, and the work that they did with PEPFAR and mostly in Africa is, well, it was important and it isn't happening anymore. And then there's also the Religion and Public Health Collaborative. This is what I was recruited to Emory to do. I definitely don't want to take all the credit for all the things that they did before I got there that are still going on, but they had already established a dual degree program so that students who were at this Candler School of Theology in the MDiv or MTS programs could get a 12-month MPH degree at Rollins. So this kind of cross-training is super important. They had established that already. There was a certificate that Rollins students or Candler students could do. And they had already held several important conferences, one of called Beliefs and Barriers with the African Religious Health Assets Program. So I came in 2009, and this is, yeah, that's the current executive committee. So right around then, 2007, 8, 9, was the same time that Michael Marmot was doing the social determinants of health for the World Health Organization, right? So this is all like in the mix here. So religion was not in the mix at all. So the entire booklet, which is a wonderful report, and I give all the credit to Michael Marmot, somehow, when you have a definition like this, which I love this definition, the circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces, economic, social policies, and politics. Well, wouldn't you think that something about global health that focuses on the global South and is about the circumstances in which people are born, grow up, live, work, and age would have some mention of religion in their 200-page book? You would think, but no. So that was easy to get a lot of people on board to say, well, we think religion should be one of the social determinants of health. It has a whole lot to do with how people are born, grow up, live, work, and age. So we, the first year I was there, we did a little seminar series, and that was nice, but then we realized we were just talking to each other and we should do something bigger. So the book that you mentioned was what came out of like a 2-year process with 35 Emory faculty members. And these people are so nice. And I was new there, and I would just send them an email and say, won't you write a chapter for my book? And this is what I want your chapter to say. I was very bossy. And they all did it. And they were so nice. And we met once a month and had lunch, and everybody would read each other's chapters on Canvas. And it was just really a wonderful, I loved all those people who were in it. So yeah, so I could talk about the book for a long time, but I won't. We did have a big conference for it when it was published, and William Fegge was our keynote speaker the first night, and that was really so great. So yeah, I think this book has some timelessness to it. But the most charming part of it is part 1, the religious practices. If you've looked at it, it's like these short little accounts, and we had such a lot of discussion matching up religious rituals and practices with religious traditions, because we didn't want to essentialize anything. And fasting is a practice in many religions, right? So it was that was a lot of fun to talk to these people about. Another conference that I'd like to mention, and this is a little bit more specifically on the topic of partnerships, was this special issue of the American Journal of Public Health that was from March 2019. And all these people, these are not just Emory people, these are from all over the world, who did series of essays and editorials about partnerships and called Finding Common Ground. And Alfredo Moravia came to Emory, and we had a really nice conference. So at that conference, we learned a lot about the Ebola crisis. Okay. This is where I could cut, but you want to hear this, I'm going to say, let's just go for it. So when I talk to like ordinary community groups, I would say, I'll bet you the first time you ever heard of the Ebola crisis was when those missionaries were being flown back from Sierra Leone to Emory University Hospital, and the CNN helicopters were like over it. And yeah, okay, well, that tells you one thing, that religion is implicated in the Ebola crisis right from the get-go, because they were missionaries and they were already there providing healthcare to people when most people in the United States had never even heard of Ebola. So that's Dr. Brantley getting off the ambulance, much to everyone's amazement. So religion and the Ebola crisis are like very intertwined. So this is why it's a good story. So this is a graph from Morbidity and Mortality Weekly Report that shows what happened at a funeral. This was a funeral of a pharmacist, the leading figure in his community. And you can see that there are a lot of D's here, which show that the person who was attending the funeral, these are all people who attended the funeral, and everyone that has a D next to their name was a death. And these little circles that have the X's on them are for people who touched the corpse. And you can see that there's a lot of people who touched the corpse. So it was identified fairly early in the crisis that one of the main transmissions in the Ebola crisis was traditional funeral practices, which would be for Christian and Muslim practices and traditional burials. It didn't really matter what religion it was. There was these practices were exactly what mainly transmitted it because it's the most infectious just before and after death. The other feature to point out here is that, you know, there's second and third generation transmission in this Morbidity and Mortality Weekly Report. So 28 people who attended the funeral contracted Ebola from direct contact with the body. So religious practices were part of the missionaries, and then they were also part of the cause of the problem. So faith leaders just played such important roles in the Ebola crisis. And so one of the problems was that the World Health Organization's safe burial practices required Black body bags and that no one be participating in any sort of ritual for the death. And people didn't accept that. So it wasn't that they didn't know that this was dangerous. It was that I as somebody who was there, gave me a quote and said, "This is my mother. I will honor my mother. I don't care what happens to me." So it wasn't just it wasn't ignorance, let's just say. It was deliberate upholding of traditions and practices that were of existential importance to people. So there was a meeting at the WHO that included faith-based organizations, especially from the faith-based organization Focus 1000 in Sierra Leone. They held a meeting in October 2014 in Geneva to develop what were called safe and dignified burial practices, to modify the World Health Organization's recommendations so that people could be safe, but also honor their traditions. And so this organization, Focus 1000, is, oh, oops, sorry, I didn't mean to do that. Oh, I want to go back. Oh, no, I only go forward. Oh, well.
If you go back, yeah.
Oh, yeah, I didn't see it. There we go. Focus 1000 is an organization that exists in Sierra Leone that focuses on the first 1,000 days of children's life. So it's a children's health organization, and they work closely with World Vision, which will come up in a minute. So Focus 1000 had already established networks of faith leaders, the Islamic Action Group, ISLAG, and the Christian Action Group, CHRISTAG, who were able to be called together for a meeting in Sierra Leone to educate these faith leaders about the new safe and dignified burial practices. And so at this 2-day meeting, all these faith leaders from all the traditions came together to develop messages, to develop sermons and teachings and text messages and ways of communicating about the new safe and dignified burial practices. And so here's just an example of a poster that would be put up to maintain. This message is from religious leaders and Focus 1000. And this is an example of a safe and dignified burial. You can see the body bags are not Black anymore, they're white. That was much less offensive to people. And people are staying at a safe distance, but a religious leader is able to say the words, sing the music, and do the things that recognize the importance of this life. So we had a conference in April, and Dave was our featured speaker. Dave was the for World Vision, was their director of Muslim-Christian interfaith relations, and was the lead operations person for the Ebola response by World Vision. And then on the second day, we had this important panel. And so a lot of it was about the importance of the faith groups, both in the missionary end of it and also in the World Health Organization end of it. At that meeting, oh wait, let me just go back. At this panel, one of the people on the panel was Muhammad Jallow. So Muhammad is the son of Muhammad Jallow Sr., who is the director and the founder of Focus 1000. Muhammad is a PhD epidemiologist and is now he's now the country director for Cameroon in Africa. He's been also in Tanzania. But he was at this conference and he said, well, I could tell you about, that meeting that my dad had. He said, I'm going to be bringing Qurans and Bibles that were used at that meeting to develop these messages to the CDC, because the CDC is mounting an exhibition of the CDC's response to Ebola. So the CDC Museum, which if you get to Atlanta and you're in public health, you should absolutely visit the CDC Museum, did this, and they had it up for a year. And I hope it's still there. I didn't test this link, but they librarians at Emory and Georgia State made a digital version of it. So you can actually still go. It was a big exhibit, and the faith leaders part of it was actually in the center. So all the other exhibits surrounded it. So this is what the case looked like. This is the Quran, and it says, this sign down here at the bottom right here says, Quran marked with religious passages supporting Ebola prevention and control measures presented to CDC by the Islamic Action Group Islam through Focus 1000. And on the other side of that case is the Bible. Oh, there's a Facebook interview of Muhammad and the curator of the exhibit. It's also fascinating. But this little word written right here says quarantine. The marked passage from Leviticus 13:4 says about leprosy. So these were some of the actual things that were at this meeting that, shall we say, turned everything around. This is a poster from the CDC exhibit. This is October when the meetings took place. These are the deaths in Sierra Leone. You can't get more dramatic than that. After the messages got out, it just fell. Religion was implicated in every bit of this story, and the fact that people were able to work together despite having somewhat big differences initially is, I think, so inspiring and should give us a model for how things can happen in the future. So then there was COVID at the institutional level. I just like this picture. This is the Salisbury Cathedral. They were doing shots. How great is that? And so I think the trusted messengers word came out from COVID, and trusted messengers were definitely clergy. And this was from Salt Lake City. So I'm looking at the clock. So I'm going to get to the third level, the state level. So we've been talking about individual level research and partnerships, and then we get to the state level. So the problems have been increasing as we've been going along, as you can tell, because states have a lot of power, and sometimes states represent some religious traditions more than they do others, and in fact can often be persecuting of people who are in minority groups. So this is one of the stories how about if I go back to this? This is like a counter theme. Anyway, you all know the Call the Midwife show. Yeah. Okay. The NHS actually did partner with this Anglican sisters to provide midwifery. And anyway, if you've never seen Call the Midwife, it's religion and public health partnerships, and it's the state because the NHS said, well, these Anglican sisters really do know a lot about midwifery. We should send some nurses over there to work with them. And this is the show, which is wonderful. They were based on the diaries of one of the NHS nurses who went initially to work with the sisters. So it is nonfiction. Okay, but there are many more examples of religion-state alliances that harm public health. And one of them is certainly about reproductive rights. Dobbs versus Jackson's Women's Health Organization took away rights that women have had for decades and decades. And seven of our Supreme Court justices are Roman Catholic. That's a lot. 1 liberal and 6 conservative. And so, they write these amicus briefs. The mainline Protestant churches, Jewish institutions, all wrote amicus briefs against the decision that did come out. But this is absolutely an example of some faith traditions, beliefs being imposed on everyone. And then there's Anthony Comstock. Okay, how many people have ever heard of Anthony Comstock before? Okay, 1. And when did you first hear about it? Pretty recently, right? Yeah, because of the Dobbs decision. I never heard of this guy at all before, but I went to Emory, and Carol Hogue, who was director of maternal and child health at CDC before she became an Emory faculty member, and her husband, a law professor at Georgia State, did a chapter on Anthony Comstock, a very right-wing fundamentalist Christian who created the laws in 1873 called the Comstock Laws. I had never heard of him before, but there's a whole chapter in the book if you want to read about him. And now everybody's talking about this guy because these laws are still on the books. So he founded the New York Society for the Suppression of Vice. And vice was the delivery or transportation of, quote, obscene, lewd, or lascivious material, as well as any methods of or information pertaining to birth control and venereal disease through the mails. So he became a special armed agent of the US Postal Service. He arrested people and threw them in jail for sending medical textbooks through the mail. 4,000 people were arrested. And so today people are talking about these laws because they do still exist. Here's some examples of stuff that's been in the press. Because mifepristone is sent through the mail. The one remaining avenue for abortion rights has everything to do with the Postal Service. So I haven't seen, this has been a little while ago that this is 2023. So I haven't heard anything more about it, but these laws are on the books, and he called himself a weeder in God's garden. So his religious fundamentalism was absolutely the motivation for everything that he did. And then there's COVID at the state level. And there was so much controversy. I was in New Jersey during the beginning of the COVID epidemic. So the New York Times was my local paper, and the local daily news was from, the police being called to funerals that had thousands of people out on the streets in Brooklyn. And so there was outright strife between religious groups and the state, and in Israel too. This is a mass burning in Jerusalem. Where did my arrow? Oh, there we go. And the Supreme Court did rule, and Neil Gorsuch wrote the statement supporting the finding that it was against the religious liberty of people for the state to say that mass gatherings were not okay. Mass gatherings like sports events and concerts and religious services. So there was outright controversy. And because I was in New York, I was paying attention to COVID. I'm in public health. And I was very aware, because I'm on a lot of mailing lists, of what the National Council of Churches was doing. Well, they were holding like 4-hour webinars on how people could run vaccination drives. or supporting Zoom learning for, people who were in congregations who didn't know anything about Zoom. And for how can choirs practice online? So, I mean, I knew there were so many people who were working hard on obeying and reducing the risk for other people, even when it meant sacrificing the weekly traditions. So I was kind of confused about these two counter messages, because it was all like religion and science are at war with each other, and the Supreme Court says it's a violation of religious liberty. And yet at the same time, there were an awful lot of big religious organizations, it seemed to me, that were absolutely on board with public health measures. So I worked with a couple of graduate students on our paper, Narratives and Counter Narratives in Religious Responses to COVID, because it just seemed like we wanted to figure it out. So we did, and I'm saying they did it. It was like running a very great graduate student seminar. These are two computational text analysis people. So we captured all of the New York Times articles that mentioned religion and COVID from January through July of 2020. And the World Health Organization's and CDC's guidance for faith communities, of which there were, I think, 9 documents, because they kept updating them. And then they scraped the websites of the faith organizations that I could find anywhere on the web to get what their COVID statement was, and dumped all of this text into a big giant text analysis and did topic modeling and sentiment analysis. I just love these guys. So the sentiment analysis was interesting, and the New York Times went from pretty negative views of religion, sentiment meaning like they put the positive and negative valences of the words that are around the keywords. And it went from negative towards positive. And these are the faith-based organizations' statements, which were all very positive. And so in terms of the sentiment about the tone, the way the thing was being presented. And then the topic modeling, which I know you can't see it all, but I can tell you that the public health organizations topics, you pick how many words you're going to do, and then you get how many topics, and it's a lot of fun to do. The top topics for the public health guidance for faith communities and for the faith-based organizations based on their COVID statements on their websites line up almost exactly. And that is not because the National Council of Churches is putting up whatever the CDC said. They were theological statements. They were absolutely about the religious traditions, and they were from the heart. They were absolutely not just copying and pasting whatever the CDC or World Health Organization said. And yet they did line up very, very closely. So there was more convergence of views among established religious groups and the public health organizations than you might have thought just looking at things in your world, because I think conflict gets more publicity in the media. And so that was a really interesting thing that we did. And I can't say that this is the be all and end all study of it, because there are many mega churches that were not affiliated with denominational hierarchies that would not have had websites with COVID statements on that. I so didn't find them. So I would definitely say that what got found, I had about 70, so it wasn't like none, but they were what could be found based on what I knew about religious traditions in the United States. So it was a fun study to do. What can I say? Vaccines. This is a really interesting study that just came out with people from Kaiser Permanente and University of Colorado. They did a study of people who were members of managed care systems of Kaiser Permanente. And there was an inverse association between how frequently people attended religious services and their positive attitudes to vaccines. So there was a wrong direction among these people who are in Kaiser Permanente. So I think that, I used to think that reproductive health was like the flashpoint for conflict between religion and public health, and now I think it's vaccines. So they're both really important and both still with us. Okay, oh, there it goes. I lost my arrow. So yeah, I'm finishing up now. We'll have time for questions. So it has been like, it's been a struggle, I would say, for me to get from the place where every study I did showed a positive health protecting effect of religion when I put it in the model. No matter what else I put in it, it was still going to be there. So that was just something I knew to be true. And then, you know, to reconcile it with all of the harm done to public health by religions in different venues was just really, you know, something I was constantly thinking about and trying to reconcile for myself. And so, you know, that this goes right along with moving from Rutgers to Emory and being involved with a School of Public Health and a School of Theology where these issues are much more in the fore. So it was really complex. I don't think that in any way invalidates the social determinant of health identification of religion. It's social determinants are not necessarily determining for good. So in struggling with this and talking with, so this is the paper that we did in British Medical Journal and 2 years ago, and Mohammed and John Blevins, who's the director of Interfaith Health Program, and Jim Cochran, who was the director of the African Religious Health Assets Program, were my co-authors on this paper, and that was so much fun to do. But it was, I think, a way to talk about the complexity, the contradictions, the difficulties, and yet, as any one of those people would tell you, the absolute necessity for people being in the middle of that conflict. I know that John Blevins says to a group of students, like, if you think religion is the worst thing in the world for public health, you better come and see me. And if you think it's the best thing in the world, you still better come and see me. So I think he does represent a really important voice. So if you're inviting people, you should invite John, if you can get him. He travels a lot. So yeah, all those things. I could probably put some more words up there, but this relationship between religion and public health is so much more complicated than it seemed like at the outset, when there wasn't too much data, but it was all at the individual level. Thinking about it at the organizational and the state level makes it infinitely more complicated. So thank you for letting me tell my little story, and I'd be happy to take any questions. We have some students in the room. Faculty. Anybody. And maybe online there are some.
Yeah, those who are online, if they would like to ask a question, they could put them in the chat and I could read them out loud, or just come off mute and ask the question. Please go ahead. You want to call? You can call on Wiley.
Yes, Wiley Mosley.
Can you hear me now?
Yes, we can.
I've worked on family planning for many decades, and as you probably know, you were given some examples with Comstock, but internationally, it's also been an issue. But it's interesting how the people who are working in the area of family planning have actively engaged religious communities. And actually, it turns out that with many conferences and working with Al-Azhar University in Egypt, that the Islamic community has been more supportive in many ways of family planning than the Christian community. I don't know if that's been summarized or not, but there's been many years of work and many documents and teaching methods, for example, with different religious faiths on how to engage the religious faith in the family planning area.
Oh, great. I love that you brought that up. Do you know the work of Jenny Trinitapoli? who worked on the Malawi Innovation and Diffusion Project. And they did a Malawi religion project that was focused very much on contraceptives. The finding of that study, which was like hyper network sampling, they had individuals that were sampled, and then they asked those individuals what their congregation was. And they found that women who were more tightly tied to congregations, attended more often, had bigger networks and had much more positive attitudes about contraception and were more likely to use it. So that was an example of the power of the social and spreading information. So she's at the University of Chicago. Her work is really great. She has another book on HIV and AIDS and religion in Africa.
Well, certainly the Center for Communication Programs at Johns Hopkins has been working on this for decades, working with religious communities. I'd say there's just a long, long history in public health and family planning.
That's absolutely great. Engage. Yes, in the room.
Yeah, thank you for this really interesting talk. I have so many questions, but I'm like trying to put together. I don't know if other people have the same thing, but I guess the question I have for you, a big picture, so I think there's two things that I'm thinking about. One is, were you able to splice at all in terms of like what level of observance, like in terms of where you have the Orthodox versus like in Judaism you have Reform, like different types of sects, and then also. It seems to me when I've been in the US context that there's also so much political affiliation that also I think might be overlapped, or maybe it's just the way it's reported. I don't know.
No, those are two great questions. So in just regular hazard models, if you have an attendance question, usually there'll be like 3 to 4 categories, and the comparison group will always be never. Usually the most frequent, but then also relatively infrequent attendance is more protective in a graduated way, like you'd expect when compared with never. So although usually you just talk about the frequent attenders comparing the ends to each other, there's usually a diminishing effect with less attendance, but still a protective effect. So I would also, what you were also saying about relatively infrequent attendance, which is more associated with holidays or seasonal observances, those kinds of things would count as some participation rather than none by comparison with never.
So just to clarify, the where I was talking about the continuum, it's less about the frequency but more about the intensity or like the rigidness of the laws or rules. At least in my lens, that's like they're like, so somebody could be going to a less observant synagogue.
I misunderstood.
But they're going every week. But and then again, just anecdotal, I believe they had felt differently when it came to COVID.
I misunderstood your question. I'm sorry.
No.
But I think it's well known that certain religious groups that have very strict rules, like Mormons and Seventh-day Adventists, also have amongst the highest life expectancy of any groups in the country. And NIH in the 1980s sort of discovered this, and they did some conferences on the low-risk populations, and they didn't say that they were religious, but they were. So people who do not drink alcohol or smoke any cigarettes or have sex with a lot of people, those are all protective factors that really play into the really extraordinarily longer life expectancies for those groups. But religious attendance overall is associated with lower smoking, even if you're not one of those more strict groups. And in fact, a lot of times you don't even know what people's religious affiliation is. The Health and Retirement Study does a great job of breaking it down amongst a lot of groups, but they mask them too because you get very small numbers. So you don't even usually have that kind of granularity, but Seventh-day Adventists themselves have been studying themselves, right? If you go to the Seventh-day, it's all about health, and thousands of studies have been written. So I think, it's, it doesn't entirely matter about the strictness of the religious faith, but it does matter to some extent. So but yes and no. And your second question was
about the political.
Oh yeah. Oh no, that's so important now. And it's so changed. I think 20 years ago, the proportion of Democrats and Republicans who said that they attended religious services regularly was about equal. And now it's not at all. Democrats are much, much less likely to be regular attenders at religious services. So there is very definitely a political divide now that is fairly new. But definitely, as you know, the Democratic Party has changed from being, you know, the party of working people to the party of people with college degrees. A lot of things have changed, but yeah, education is one of the biggest predictors of not attending religious services. So
there's a question in the chat from Michelle Bedoya, which says, I find myself often thinking about the relationship between policy and religion, especially how US public health is constantly trying to balance religious autonomy's individual liberty and the obligation to protect population health. So autonomy, liberty, and population health. Any thoughts on how, about where the balance should fall?
well, that's the COVID story, isn't it? I mean, it just brought all of those conflicts out into the open. And I'm not a legal scholar really at all, so I don't know if I will have a very bright answer for your question, but I think that finding that balance in a very religiously diverse society is extremely difficult. We have so much religious diversity, and then among all of the religious affiliations, we have gradations of how observant people are, and none of those line up perfectly with religious liberty.
The question here, and it's kind of related to one of mine as well. Thanks for a great talk. This is from Andrew Natala. I'm curious what you think are some of the big unanswered questions in the field, and where newer researchers interested in these intersections between religion, spirituality, and public health should be focusing some attention for the years ahead. So so you talked us through the individual, the meso, the institutional, for example. What's the next frontier for religion and spirituality, public health researchers to explore?
That's a very big question. Yeah, well, I feel like I've been moving and I'm finding out where I am at all times, but I would say that going to, you know, focus on the pain is a good idea. To focus on the biggest areas of conflict and bring the smartest possible people together to find some kind of common ground. You know, people to work together, people don't have to agree about everything. They really just need to agree about one thing. And if you focus on that one thing and you can work together, you can establish some trust for maybe doing something else that's related. So I think that should be absolutely the way that the art of bringing together faith traditions and public health has to be. I mean, just to say like, okay, the majority of things we don't agree about, that might be true, but find the thing that you do agree about. And even in Congress, sometimes they can do that. If surely people in public health and religion can do it.
Yeah, I think we're.
A question, yes.
Yeah.
Real quick, but related to it, kind of next steps. Do you consider bringing in the discipline of moral psychology and see how it overlaps with religion and then how that impacts policy? Is that something you're looking at?
It's not really. I guess I'm not a psychologist, and I tend not to think that way at all. But it seems like a good idea, and yeah, I mean, I think that the ethical and moral dimensions of these are, we were talking about earlier about the mission-driven nature of public health and the mission-driven nature of people in schools of theology. Seems like it would be related. I feel like I'm not the best person to answer that question either. And here's another one before we run out of time. Yes.
Oh, okay. So this might be a good closing statement, actually. I forgot to point out, I thought it was really great that you showed that example in Sierra Leone of like how they were able to find compromise. And it reminded me, I was listening to a webinar yesterday about public health communication and lessons from COVID, and it was very similar. So the point was like, rather than shutting people down and say you're wrong, listen to them and find out what their concerns are. So I'm actually thinking now, based on some of these questions about where the next thing is, maybe religion can help guide us in that. In terms of finding some ways that there could be pathways forward. So I thought that slide was great to show that.
Well, thank you. Yes, I take no credit for that at all. I just know some people who knew the people. And so I was able to tell their story. But the important thing about responding to an emergency, which is so relevant to public health, right? We have public health emergencies and we have to respond to them. The thing about this Focus 1000 group was that they had already established those networks of faith leaders in their country. They already knew each other. They didn't really like meet all the time, but they kind of, had already networked with each other enough to be able to be called in the time of this crisis to work together to do something. And so the interfaith efforts are so important in communities, even if they're kind of lying dormant a lot of the time. The fact that they can be activated when needed be is, I think that's a key place for for public health to go. And I'm just remembering wise words of deans of school of public health, as I shared one earlier with you, but another wise word from Jim Curran, the longtime dean of the Rollins School of Public Health, he said, yeah, well, we get together with the interfaith groups. I always find like they want to talk to each other more than they want to talk to us, which didn't mean not to be there, but yeah.
Thank you. Well, we are at time. There's another question in the chat, but I feel like that's one that we can pick up when we're chatting afterwards. But
Okay.
But I just want to thank everyone for being here. Thank you very much for those who attended in person. Don't forget to grab a muffin or a cookie and a cup of coffee on your way out. And to those of you who joined us on Zoom, thank you very much.